is factors modifying drug action. So here I'll be giving you a list of factors that modify drug action and explain the underlying reasons for the alteration in drug response. So what is the reason for the differences in drug response? Alteration in drug response can be due to 1. Variation in the pharmacokinetic handling of drug. So differences in absorption, distribution, metabolism and excretion alters the drug response. There can also be a variation in the pharmacodynamic actions of the drug. For example, a drug binds to the receptor, activates the receptor, sends a signal to the affected organ, which in turn produces a drug response. Changes in the receptor number, the state of the receptor, whether it is in a sensitized state or it is in a desensitized state to the agonist, and phosphorylation of the receptor, the coupling proteins, the signaling proteins can lead to decreased response or lack of response. So coming to the factors that modify drug action. The first factor, body weight. The dose of the drug can be mentioned in terms of milligram per kilogram body weight or total single dose for an individual weighing 50 to 100 kilograms. For Indians weighing less than 50 kilograms, smaller doses are required. However, the doses expressed in this fashion may not be applicable for excessively obese individuals or those with dehydration, emaciation or having edema. The next factor is age. The pharmacokinetic and pharmacodynamic actions of drug differs with age. Infants are not just small adults. There are important physiological differences compared to adults. For example, in infants, the gastric motility and the gastric pH fluctuates in neonates and infants, and this decreases the absorption of most drugs. Secondly, infants have low GFR and the tubular transport system is immature. Therefore, drugs that are excreted by glomerular filtration such as gentamicin and those that are secreted through the tubules, for example penicillin, is prolonged 3 to 5 times. Thirdly, the hepatic drug metabolizing system is inadequate in infants and neonates. So, chloramphenicol can cause grey baby syndrome in infants. Also in infants, the blood-brain barrier is permeable to most drugs. So, unconjugated bilirubin can easily enter the central nervous system and can cause kernicterus, and this effect is mostly seen in premature infants. The transdermal absorption of drugs is faster in infants because the skin is thin and highly permeable. Absorption through the rectum is rapid and predictable. Therefore, diazepam solution is given rectally to control febrile seizures in children less than 5 years. Also, it needs to be kept in mind that children are growing and they are susceptible to special adverse effects. For example, corticosteroids inhibit growth in children. Androgens can cause early fusion of epiphyses leading to stunting of stature. Tetracycline gets deposited in growing teeth and discolor or deform the teeth. Dystonic reactions are more common with phenothiazines in children. Also, for prescribing drugs in elderly, particularly after 60 years, the pharmacokinetics and the pharmacodynamics of drug must be considered. In elderly, the absorption of most drugs is delayed. This is due to slow intestinal transit and decreased intestinal blood flow. Secondly, the volume of distribution changes. This is because in elderly, the body fat increases but the proportion of body water decreases and the lean body mass decreases. Also, the plasma albumin level may be lower. So, these changes can alter drug disposition in elderly. Also, as the age advances, the liver and the kidney mass decreases and the blood flow to these organs decrease. So, this results in reduced metabolism and decreased excretion of drugs. This in turn leads to accumulation of drug and prolonged T-half. This necessitates dose adjustment in elderly. When it comes to pharmacodynamics, the elderly are more sensitive to CNS drugs such as neuroleptics, sedatives, hypnotics, and respiratory depressants. Also, the beta-adrenergic receptors are less sensitive to agonists and antagonists. This leads to alteration in drug response. Elderly are more prone to postural hypertension due to reduced sensitivity of baroreceptors. Due to prostatism in elderly male, even mild anticholinergic drugs can cause voiding difficulties in elderly. The elderly are likely to be on multiple drug therapy for diabetes, hypertension, arthritis, and so on. This increases the chances of drug interaction in case of elderly. Elderly also suffer from senile dementia, therefore compliance to drug therapy needs to be monitored. The next factor is sex. Females have a smaller body size and require doses at the lower side of the range. Certain adverse effects are more common in males than in females. For example, antihypertensives such as clonidine, methyl-dopa, diuretics, beta blockers have the potential to interfere with the sexual function in males but not in females. Gynecomastia is a side effect of ketoconazole, metoclopramide, chlorpromazine and digitalis in males but not in females. Ketoconazole causes loss of libido in males. While prescribing drugs in women, consideration must be given during pregnancy, lactation and menstruation. In pregnancy, there are marked and progressive physiological changes, particularly in the third trimester of pregnancy. So the GI motility is decreased. This leads to delayed absorption of many drugs. Secondly, the hepatic microsomal enzymes undergo induction. So due to increased synthesis of microsomal enzymes, the drugs are metabolized faster and higher doses are required for drugs that are dependent on liver for metabolism. Thirdly, the renal blood flow increases, so polar drugs are eliminated faster. Fourth, the plasma and extracellular fluid volume increases. Due to increase in blood volume, the cardiac output and the workload on the heart increases. So this increases the chances of heart failure. Therefore, the requirement of digitalis and diuretics in heart failure increases. Also in pregnancy, the placenta makes hormones that are responsible for the buildup of glucose in the body. If the body is not able to make enough insulin, there can be a pregnancy-induced diabetic state. Drugs administered to the mother can also affect the fetus. Certain drugs can cause teratogenic effects on the fetus. For example, phenytoin can cause Hydantoin syndrome in the fetus. Diethylstilbestrol administered in the mother can cause vaginal adenocarcinoma in the child after puberty. Certain drugs administered to the mother can have therapeutic effects on the fetus. For example, corticosteroids induce maturation of the lungs in the fetus. Phenobarbital is administered to the mother as it is an inducer of hepatic enzymes. Due to increased synthesis of enzymes, it can cause glucuronidation of bilirubin. This lowers the chances of jaundice in neonates. The next factor is route of drug administration. Route of drug administration governs the speed and intensity of drug response. For example, parenteral route causes more rapid and predictable drug response compared to oral route. A drug can have entirely different uses through different routes. For example, magnesium sulfate administered orally can cause purgation, but when applied locally on joint sprains decreases the swelling. Magnesium sulfate when administered intravenously can cause CNS depression and hypotension. So the next factor is pathological states. Various disease conditions can alter drug disposition in several ways. In GI diseases, the absorption of drugs can be increased or decreased. Malabsorption syndrome does not necessarily decrease the absorption of drugs. For example, in celiac disease, the absorption of amoxicillin is decreased, whereas the absorption of cephalexin and cotrimoxazole is increased. Achlorhydria is a condition where there is absence of hydrochloric acid in gastric acid juice. Achlorhydra favors ionization of aspirin and this decreases the absorption of aspirin. NSAIDs can aggravate peptic ulcer and therefore avoided in patients with peptic ulcer. The next factor is hepatic diseases. Hepatic diseases, particularly cirrhosis, can alter drug disposition in several ways. Liver is the primary site for drug metabolism. So cirrhosis of liver slows down the metabolism of several drugs and this leads to accumulation of drug in the plasma, thus leading to the prolongation of T-half and this requires dose reduction. Alternative drugs can be used that are not dependent on the liver for metabolism or drugs with a shorter T-half can be used. For example, oxazepam can be used in place of diazepam because oxazepam is an active metabolite of diazepam and also it has a shorter T-half. Secondly, drugs that have high first-pass metabolism achieve higher bioavailability. This is because of liver dysfunction, so the drug directly reaches the systemic circulation leading to higher bioavailability and this in turn requires dose reduction. Prodrugs or inactive drugs require activation in the liver to produce a drug response. Hepatocellular dysfunction leads to decreased efficacy of these drugs, so alternative drugs can be used that are not dependent on liver for metabolism. Next, liver is the site for the synthesis of clotting factors. So liver disease such as cirrhosis can decrease the synthesis of clotting factors leading to coagulopathy. Therefore, oral anticoagulants are avoided in patients with cirrhosis. Also, sensitivity of brain to CNS depressants can be increased. For example, benzodiazepines, barbiturates and opiates can lead to coma even at normal doses. Diuretics in patients with cirrhosis can induce hypokalemic alkalosis and this favors the conversion of ammonium to ammonia which readily penetrates the blood-brain barrier and can precipitate mental changes in hepatic encephalopathy. The next is renal diseases. Clearance of drugs that are excreted unchanged in urine is reduced in kidney diseases. For example, digitalis and aminoglycosides are excreted unchanged in urine and in kidney diseases the excretion is affected, the T-half is prolonged and this requires dose adjustment. Nephrotoxic drugs such as tetracycline, sulfonamide, cyclosporine, penicillamine, vancomycin should be avoided in renal diseases. In renal diseases, the plasma albumin level is decreased. So this decreases the binding of acidic drugs, thus increasing the concentration of free drug in the plasma which is readily eliminated and removed from the body. In renal disease, the permeability of blood-brain barrier is also increased. So this increases the sensitivity of the brain to barbiturates, benzodiazepine and opiates. Thiazides administered in renal failure can decrease the glomerular filtration rate and worsen uremia. Potassium-sparing diuretics can cause hyperkalemia and induce hyperkalemia-induced cardiac depression. Fenformin can induce lactic acidosis in chronic renal disease. The concentration of urinary antiseptics such as nitrofurantoin and nalidixic acid is reduced in urine. This leads to accumulation of the drug in the systemic circulation leading to systemic toxicity. So the next disease state is congestive heart failure. Congestive heart failure can alter pharmacokinetics and pharmacodynamics of drugs and modify drug response. Heart failure is characterized by congestive symptoms and poor perfusion to vital organs. Due to congestion of intestinal mucosa and splanchnic vasoconstriction, there is decreased absorption of several drugs. Also, because of congestion in the liver, the metabolism is slowed and the elimination of drugs is decreased. This leads to prolonged T-half and dose adjustment is necessary. Also in heart failure, the extracellular fluid volume increases and this increases the volume of distribution of most drugs. On the other hand, there can be poor perfusion to vital organs. So this decreases the volume of distribution of drugs. So volume of distribution can increase or decrease in heart failure. Also, a decompensated heart is sensitive to the action of digitalis. So this is how heart failure modifies drug action. The next factor is thyroid dysfunction. In hyperthyroidism, the metabolism of drugs is increased. Due to increased metabolism, there is lower levels of plasma digitalis and larger doses may be required. In hypothyroidism, there is slow metabolism. This leads to accumulation of drug and so the plasma digitalis levels are high. Therefore, lower doses of digitalis may be required in case of hypothyroidism. Next is genetic factor. Variation in human genome can determine differences in genetically mediated disposition of drug. This is known as pharmacogenomics. This is usually due to defective or deficient enzyme system that is responsible for metabolic inactivation of drugs. Isoniazid is an anti-tubercular drug which undergoes acetylation in the liver and this is controlled by an autosomal recessive gene. There can be slow or fast metabolizers of isoniazid. The slow metabolizers of isoniazid result in slowed metabolism leading to accumulation of drug in the plasma and this increases the incidence of side effects such as hepatotoxicity and peripheral neuritis. Whereas fast metabolizers metabolize the drug rapidly and this decreases the therapeutic effect of the drug. Therefore, fast metabolizers metabolize the drug quickly and this results in reduced therapeutic effect of the drug. Similarly, phenytoin is inactivated in the liver by hydroxylation. So, defective hydroxylation leads to accumulation of phenytoin leading to marked phenytoin toxicity. The next example is that of succinylcholine, a depolarizing neuromuscular blocker which acts as a muscle relaxant. Succinylcholine is hydrolyzed in the plasma in presence of a cholinesterase enzyme. Some individuals have a modified form of cholinesterase enzyme which is also known as atypical pseudocholinesterase enzyme. So this causes slow hydrolysis of succinylcholine leading to accumulation of the drug and prolonged T-half. So increased concentration of succinylcholine can lead to succinylcholine-induced apnea. The next example is deficiency of CYP2D6 enzyme that is responsible for the conversion of codeine to morphine. Codeine is indicated for the relief of mild to moderately severe pain. So codeine is converted to morphine which is its active metabolite which provides its analgesic effect. So there can be slow metabolizers or ultra-rapid metabolizers of codeine. Slow metabolizers of codeine leads to reduced morphine levels. This decreases the therapeutic effect of codeine and the pain relief is inadequate. Whereas ultra-rapid metabolizers convert the codeine to morphine rapidly and this leads to increased levels of morphine and morphine toxicity with a normal dose of codeine. Next, we will learn about tolerance and tachyphylaxis that are responsible for decreased drug response. So what is tolerance? Tolerance is requirement of a higher dose of drug to produce a given response. It is of two types, natural tolerance and acquired tolerance. Natural tolerance is common among animal species and among various human races. In species tolerance, certain animals require higher doses of drug that can be lethal to man. For example, rabbits are tolerant to large quantities of belladonna or atropine. This is attributed to the presence of atropine esterase enzyme in the liver and plasma which detoxifies belladonna and therefore rabbits are intolerant to large quantities of atropine. In human races, Negroes are tolerant to the actions of mediatrix. For example, a solution of ephedrine instilled into the conjunctival sac of Caucasians can cause prompt dilatation of the pupil, whereas in Negroes there is no dilatation of pupil. Acquired tolerance develops with repeated administration of drug at intermittent intervals and may take weeks and months to develop. For example, benzodiazepine, barbiturates, nitrates, xanthines are known to develop tolerance. Tolerance may not develop equally to all actions of a drug. Tolerance occurs to the analgesic and euphoric action of morphine, but constipating and myotic actions do not develop tolerance. So what is cross tolerance? Cross tolerance is when tolerance occurs to pharmacologically related drugs. For example, an alcoholic is relatively tolerant to barbiturates and general anesthetic agents. Next is what is tachyphylaxis? Tachyphylaxis means rapid development of tolerance. The doses of drug administered in quick succession results in marked decrease in the response. This is usually seen with indirectly acting sympathomimetic agents such as amphetamine, tyramine and ephedrine. These agents cause release of catecholamines from the storage vesicles of the nerve terminals, leading to exhaustion of the mediators, the synthesis of which does not match with the release. So exhaustion of mediators is one of the mechanisms for the development of tachyphylaxis, and this is usually seen with sympathomimetic agents such as tyramine, ephedrine and amphetamine. So now we move on to the mechanisms that are responsible for the development of tolerance and tachyphylaxis. So the mechanisms are 1. Change in the state of the receptors, 2. Loss of receptors, 3. Exhaustion of mediators, 4. Altered drug metabolism, 5th. Physiological adaptation. So what are the mechanisms? 1. Change in the state of the receptors. Receptors linked to ion channels show pronounced and rapid desensitization. In this case, the agonist binds to the receptor, resulting in receptor activation and opening of the ion channels, allowing the movement of ions inside and producing a therapeutic response. A desensitized state is produced by the conformational change in the receptor, which results in tight binding of the agonist to the receptor without any opening of the ion channels. So due to lack of inward movement of the ions, there is no response. A second mechanism by which desensitization is caused is phosphorylation of the receptor and inactivation of the receptor. So phosphorylation of the intracellular region of the receptor results in a desensitized state and tolerance and lack of drug response. Similarly, most G-protein coupled receptors also show desensitization and drug tolerance. These receptors are coupled to G proteins, which activates the second messenger system and produces a drug response. Phosphorylation of the second messenger system causes desensitization of these receptors, leading to tolerance. Next mechanism is loss of receptors. Prolonged exposure of the receptor to the agonist results in the decrease in the number of cell surface receptors. This is due to internalization of phagocytosis of the receptors and decreased therapeutic response and tolerance. The most common example is beta-adrenergic receptors, which show internalization or decrease in the number of receptors on exposure to the beta-adrenergic agonist. This is a gradual process and takes weeks and months to develop. Use of exogenous gonadotropin releasing hormone in the treatment of prostate cancer. It is to be noted that prostate cancers need androgen for growth. In a normal individual, GnRH is released from the hypothalamus in a pulsatile fashion, which stimulates the pituitary and the release of androgens and increases the concentration of androgens. However, exogenous GnRH causes continuous stimulation of the receptors of the hypothalamus, leading to desensitization or loss of receptors of the hypothalamus and inactivation of the hypothalamic pituitary axis. Due to inactivation of hypothalamic pituitary axis, there is decreased levels of androgen, and this is helpful in the management of prostate cancer. The next point is exhaustion of mediators. We have learned that tachyphylaxis develops rapidly in case of sympathomimetic agents such as tyramine, ephedrine and amphetamine. This is due to exhaustion of mediators, as these agents cause rapid release of catecholamine stores from the nerve terminals, and these stores are not replenished, and therefore there is deficiency of catecholamine stores or exhaustion of these mediators. This leads to a reduction in therapeutic response and development of tolerance. The next point is altered drug metabolism. Drug tolerance or tachyphylaxis may develop due to increased metabolism or decreased metabolism. For example, phenobarbital is an inducer of hepatic microsomal enzymes. Due to increased synthesis of enzymes, there is increased metabolism of other drugs, thus lowering their levels in the plasma. Phenobarbital also has the property of auto-induction. That is, it induces its own metabolism, thereby decreasing its own level in the plasma, leading to tolerance and decreased drug response. Use of nitrates as an antihypertensive agent. Nitrates act as vasodilators by releasing nitric oxide in the smooth muscles of the cells. So the metabolism of nitrates to nitric oxide is responsible for vasodilatation and blood pressure lowering effect of nitrates. Or decreased conversion of nitrates to nitric oxide results in decreased response and development of tolerance and tachyphylaxis. So this is an example where tolerance develops due to decreased metabolism. So tolerance can develop due to increased metabolism, an example of which is phenobarbital, which is an inducer of metabolic enzymes, and tolerance can also develop due to decreased metabolism, an example of which is nitrates acting as a nitrovasodilator and is useful as an antihypertensive agent. Next point is physiological adaptation. For example, thiazide diuretics has a blood pressure lowering effect by causing increased excretion of sodium and water from the body, decreasing the blood volume and decreasing the blood pressure. However, when the blood volume decreases, there is compensatory activation of the renin-angiotensin-aldosterone system, producing angiotensin II and aldosterone. Angiotensin II is a vasoconstrictor and aldosterone causes increased absorption of sodium and water. Both acting together restores the blood volume and increases the blood pressure. Therefore, the homeostatic mechanism nullifies the effect of thiazide diuretics. That is, the homeostatic mechanism produces opposite effect of that of the drug. So the drug response decreases. Next is active exclusion of drug, and this is usually seen with cancer chemotherapeutic agents where the drug is excluded out from the cells, leading to drug resistance or drug tolerance.
This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.